Well, hello, everyone. This is Dr. Asha Devereaux, and I am honored to be one of the presenters and moderators for this session on allocation of scarce critical care resources in COVID-19, a discussion of regionalization and implementation. I know this is a topic of interest in our medical community as we are facing scarcity of resources on a day-to-day basis. I'm honored to present Dr. Dan Hanfling with Inova Fairfax and Dr. Jeff Dichter with the University of Minnesota. And we have been partners on this endeavor with a whole host of other folks on this task force for mass critical care and multiple different panels where we have actually been thinking about how to allocate scarce resources in mass critical care during a pandemic. So, and have published on the topic with thought processes and leadership from over 125 thought leaders in critical care, pulmonary medicine, emergency medicine, triage, public health, nursing, respiratory therapy, and pediatrics. So with that, I'd like to turn the slides over to Dr. Dan Hanfling to discuss triage response, the framework for mass critical care, as well as resource delivery.
Great, thanks. Thanks very much, Asha. So I'll take you through this framework very quickly. And of course, all these resources will be available to you to take a deeper dive, take a longer look if you're interested. So the federal government actually sort of cracked the glass ceiling, if you will, with regards to a discussion on allocation of scarce resources, essentially rationing healthcare in a large-scale emergency, with the publication of a document in 2007 that actually described what was then referred to as altered standards of care. And this slide demonstrates what I call the Goldilocks approach to being able to manage an overwhelming number of patients. Those who are too sick to actually benefit from care, those who are too well, oftentimes we refer to them as the walking wounded, or, the too well to receive care, and then those who are optimal for treatment. And in breaking that glass ceiling, there was not a lot of interest in taking up that topic until the last pandemic that the country faced, which was a decade ago with H1N1. And in between the first and second waves of the H1N1 influenza, the Assistant Secretary for Preparedness and Response at the Department of Health and Human Services asked the National Academy of Sciences to undertake a exploration of what the standards of care should be in a large-scale disaster event. And this led to the National Academies issuing 3 reports in 2009, 2012, and then 2013 that described what we then just called crisis standards of care. Crisis standards of care being defined as a change in the usual operations of healthcare delivery made necessary by a pervasive, long-standing emergency. If you think about the key elements of that definition and those words right now, that exactly describes the situation with COVID-19, a pervasive, long-standing emergency. It's not just a busy night in the emergency department on a Saturday night. It is really the need to fundamentally change the delivery of healthcare services. So in pulling together this work, and we convened over 2 committees, over 3 different reports, we put together a systems framework that describes catastrophic disaster response. And I'll highlight for you very quickly the key elements. The key elements are based on the foundation that you see in this pictograph. The ethical considerations and the rule of law are never more important than in a large-scale disaster. And I'll ask you to think about that as we come back to Dr. Dichter's presentation, because it's the ethics and the rule of law that actually govern our response in these events, where we recognize the ability to deliver care has got to change. The steps represent key recommendations and key requirements that are needed. The first step being provider engagement. That is the fact that you're listening to this presentation today. which demonstrates that you are participating and actively engaging in recognizing that this framework is of need in the context of the crisis that we're facing now. And then you can see the other steps there. I would note that the top step demonstrates performance improvement. Performance improvement suggests that even in a disaster, we need information, we need situational awareness, and we need clinical evidence to help us make those mid-course corrections to be able to address patient needs. And, you know, as we're even learning from the COVID-19 outbreak, you know, clinical information is changing with regards to how we deliver those scarce resources to try to benefit the most patients that we can. So when we talk about crisis standards of care, we talk about transition of care across sort of a spectrum of surge response. That spectrum ranges from conventional care through contingency care to crisis care. And in the context of critical care, you see the increase in capacity that we attributed to those changes. In other words, at crisis standards of care, you have to figure out how are you going to surge your critical care units by 200%. Not an easy solution, but of course, solutions that many of you are engaged in currently with regards to preparing your own facilities for managing this potential surge in patients. You can see in the response strategies a number of key elements that we highlighted: conservation, adaptation, substitution, reuse, and in the worst case, under crisis standards of care, reallocation of resources. Again, many of these principles are those principles that you are probably employing in your own preparations right now. And so sticking with the conventional contingency and crisis spectrum, where you see that as you move across that spectrum, the morbidity and mortality increases and the demands on resources increases. And those resources are described on the right-hand side, on the y-axis, if you will, as space, staff, stuff, and then the resources. So you can see how we have put this together. Probably too much to take in, you know, just on this first blush, but something that we would encourage you to go back and take a look at if it will help you in your own preparations for critical care surge planning. And so I'll conclude by pointing you to two documents in the literature, both published over the last month. On the left, our piece that we wrote on a duty to plan, the fact that we have actually the responsibility to plan for crisis standards of care, and that planning is really not an option. And in fact, having a plan probably portends to a much better outcome than if you don't have a plan and just make ad hoc decisions. And then, and that was the paper that we published on March 5th. It's available on the web. And then I was asked to lead an effort under the auspices of the National Academy of Sciences. And we generated a rapid expert consultation to the Assistant Secretary of Health and the Assistant Secretary for Preparedness and Response at HHS, published on March 28th. And this also is available on the web, highlighting the overarching principles and the rationale for planning and implementing crisis standards of care. With that, I will turn it over, Jeff, to you.
Thank you, Dan. Looking at some of the ethical considerations when you're thinking about triage of scarce resources, as Dan highlighted, there's a whole infrastructure of planning, looking at your resources to be able to plan for up to 200% above capacity. And I know that most of us in the United States, particularly those in leadership and at the organization's health system and hospital level, have been spending a lot of time on this in the last several months, particularly the last several weeks. But it's important to realize there are a lot of ethical priorities that go into how you construct a standard of care. But there is a couple of really important principles. And number one, as Dan has alluded, to be able to utilize your full capacity, not just in a hospital or health system, but across a region, to be able to communicate that capacity, to know that everybody is really at the limits of their capacity before you start to consider triage of scarce resources, limiting resources that would otherwise be life-saving. And operationally, probably the most important thing is trying to do the most good for the most number of patients. It's also to be the most fair to as many patients in the process as we can, looking at all populations across our communities and across our society. There are many other considerations, but trying as best we can to be fairness, to do the most good, and when all is said and done, to be transparent, so that when the crisis is over, we can look at it. People will know that other people will know that it was done as fairly as we could do it, that it was just transparent, that it was documented, and hopefully that we'll learn from it. As Dan had noted, performance improvement. How do we learn from it real time? How do we learn from it moving forward? When looking at crisis standards of care, you have to look at the bigger picture of how it becomes an operational document. The first thing that you look at is what are the triage criteria that you would use? What are the standards? How are you going to look at a population of patients and realize, well, who should get the resource and who may not be able to get the resource? And although addressing the specific criteria is beyond the scope of our talk, some of the things that people have looked at is looking at an organ failure assessment tool, such as the sequential organ failure assessment tool called SOFA. And there are certainly others similar to that, Apache and multiple organ dysfunction syndrome, for instance. Looking at comorbidities of patient populations, typically patients who have heart failure or end-stage lung disease, other severe illnesses, particularly if they're end-stage illnesses, may portend a poor short-term prognosis in the setting of a crisis such as a pandemic. And as well as the duration of how long that resource, such as a ventilator, is going to need to be used. And these are all criteria that go into building a criteria that any hospital or health system or region will want to use to try and decide what the resources are and how to go about assessing who gets that resource and who may not receive that resource given the circumstance. As Dan alluded to as well, it's crucially important to have an infrastructure, not just for the criteria, but to have a triage team, which Dr. Devereaux is going to speak a little bit more about, as well as a system level oversight of the entire triage process that's occurring. Number one, it's important to realize when you're completely out of resources to be able to where you're left in a position having to triage. Equally, it's important to recognize when resources start to become available, so the need for triage may start to diminish or go away altogether. So it's by its nature going to be a dynamic process whereby the resources may be limited, they may become more available, and the degree of triage should only be based on the degree of, if you will, need or shortfall of the level of resources that you have. There are going to be different surge levels during a crisis, particularly during a pandemic. We are already 3 to 4, 5, 6, 7 weeks into this, and by most projections will last for at least several months going forward. And the peaks and valleys for any particular region or state or nation, such as the United States, may vary up and down as we go forward until that peak of demand has been met, and it starts to recede. And so health systems, hospitals, regions have to be prepared to surge upwards and possibly need your triage criteria. And there may be times where all of a sudden the surge decreases and the resources become available again. So for all of us, we have to be able to build a system whereby we're able to manage this at a really system level with ongoing information input and assessment to know when we're at a point where we have the resources and when we're at a point where we have to start reallocating or limiting those resources. Again, for any health system, any region, state government, or even a regional government, there's a dynamic involved where an incident command center is going to be able to look at the resources, make decisions with local teams, a system level team and local teams as to how to limit those resources and how to stop limiting them when resources become available again. And it's written here as the boxes are in a circle. And the reason for that is obviously because it's going to be a cyclic, dynamic, a cyclic assessment as resources rise and fall, depending upon the nature of the crisis.
Well, thank you, Jeff and Dan, for setting up this next part of the conversation. Many communities are right now facing, how do we implement this? How do we communicate with each other? How do we share resources? What is a hospital incident command system? And our recommendation is that it is time to start that communication process, talk to hospital leadership. Maybe your county medical society can facilitate some of these conversations and get all hospital leaders together and start having this conversation. And in order to deliver a change in your standards of care during this crisis situation, you will need to have some type of a triage officer identified within your institution, and that triage officer will have to be in constant communication at the Hospital Incident Command Center. And that isn't a common operational concept at this time in San Diego. We're familiar with lots of disasters, but physicians aren't always in the command center. But during COVID-19, that level of expertise will be needed. And it is advised that a triage team form, and no more than 3 people, and should have an experienced intensivist or somebody with critical care training. And due to the nature of the staffing shortages right now, retired clinicians would be an ideal source or pool to choose from. They are very highly experienced and seasoned and can make rapid decisions if needed. It's also important to have an admin assistant as a member of the team, and as well as another triage officer. 2 physicians probably would be ideal so that difficult decisions can have a 2-physician look at that. And then this team needs support. They will need interface with the clinical teams, but it's recommended that they remain sheltered and make decisions in an unbiased manner. They may need support from palliative care, bioethicists, the legal department of your facility, pharmacy, social services, pastoral care. And they also will be involved in communication of decisions through the attending physician who had requested a resource. This triage team will also interface with external sources, maybe a community dashboard with the county administration offices, and be aware in real time what exists at neighboring facilities, and they will be helping to procure resources. So this, even though they're just a few people tied into your hospital incident command, they will be instrumental in procuring resources, helping with incident command and identifying the needs in advance of running out. And that's something that they'll have their finger on the pulse with. And as Dan and Jeff had mentioned, triage and resources will become available and then may not be as available. And this is a way for everybody to have that situational awareness. So if you get into a crisis situation, it is important to know that a hospital should not determine this on its own, that we've suddenly run out of a critical care resource and that we're going into crisis care mode. It requires that foundation that Dan had shown, and it will require that regional or state or national authority to declare that a crisis situation exists. And once that has been identified, the protocol that will be chosen will also have been pre-identified. Many regions are right now formulating these processes, and there are many protocols that are available, and some of them we have listed at the end of this presentation. But the thought process is fairly straightforward and should follow the protocols that have been identified. One of the main concerns that a lot of providers have had, and it's a palpable fear, is liability issues. And when a crisis care situation has been identified and authorized by a state government authority or national authority or even a county-wide authority based on a plan that has been formulated and vetted, and it can be done quickly if necessary, there should not, and you're following that protocol and that standard that has been established, most agree that there should not be any liability as long as the protocol is being followed. When people deviate from the protocol, that's when there may be a risk for some liability. I'd also like to invite Dan and Jeff to have a conversation about this particular issue, since this is probably one of the first times we're getting this close to it.
Yeah, thanks, Asha. I would just say that plans are important, and in the absence of a plan, you may find yourself or your healthcare institution at greater risk for liability. That's been demonstrated from similar experiences, specifically during Hurricane Katrina. So the absence of a plan does not bode well with regards to legal protections. That being said, this is still unprecedented, uncharted territories, and a jury that would be asked to weigh in on decisions about withdrawal of ventilator, I think would take into account the existing circumstances within the healthcare community and the community that, within which that healthcare facility is placed, as part of their overarching consideration of how to think about actions that are taken. So unprecedented, no existing case law with regards to not just withholding, but withdrawing patients from care. And I think a plan is critically important.
Absolutely, Dan. This is Jeff here. This really requires planning ahead of time for the crisis standards of care. But when an organization, when a region, a state finds itself in the midst of this, it really highlights the importance of the partnership between the healthcare community as well as the local and state governments. Few states have any laws that govern the circumstances and what should or shouldn't happen in crisis standards of care. And yet the states will have to involve themselves in it if we get to that point. And so having a plan for how to do it, working with yourself, your partners, regionally and at the state level, and being prepared is crucial. And at some point, you depend upon the government to help support that standard of care once you're in the crisis. It would be ideal to be able to have had all these things worked out ahead of time. But in our country, we've never faced this circumstance before. And part of the daunting challenge of our moment, this moment in history, is that we are really faced with possibly having to address this challenge.
So I'd like to thank our panelists. This was an excellent conversation. I know it was a rapid overview of crisis standards of care, allocation of scarce resources, ethical principles on distribution, and then how to implement this in a fast manner. I think we've highlighted the need for plans. There are some excellent plans and documents available, and I've got them listed here on this slide. And I think community conversations are fundamental. Sharing of resources is very important, so hopefully we can prevent a crisis standard of care being implemented, and hopefully everyone can continue the camaraderie and sharing of resources and form regions that can extend even statewide so that we don't have to face this situation. Any last thoughts, Jeff and Dan?
It's really hard work to develop these kind of triage protocols and these processes. So just know that it takes a lot of work amongst yourselves, your colleagues, and your regional partners.
Agree. And thanks very much for the opportunity to present with you guys today.
Thank you.
Thank you.